and Medical Toxicology at Emory University in Atlanta, Georgia, and at the American University of Beirut in Lebanon. It is my honor to welcome you to the beautiful city of Istanbul. I also want to share with you that I'm one more affiliation, that I'm also the Assistant Medical Director of the Georgia Poison Center. So not to forget, I have many affiliations, so please apologize for forgetting one. And Georgia, Tbilisi, Georgia. So welcome to the beautiful city of Istanbul. This meeting has been a lot of hard work and passion for toxicology on behalf of Minatox and as well as on behalf of the Emergency Physician Association of Turkey, that I thank sincerely for their support and their coordination and collaboration. I want to thank Dr. Bashar Jandar, Dr. Mohamed Gul, and Dr. Bashat Al for their staunch support to medical toxicology in Turkey and in the MENA region. Today you are participating in a course that is very dear to my heart. The course is titled Bridges Between Clinical Toxicology and Public Health. I selected the title very carefully because Istanbul is the sign and symbol of bridges between different cultures, between different continents. And I could not find a better title for this course today to really embody what we believe in as toxicologists. Medical toxicologists are also bridges. We are bridges with clinical medicine. We are bridges with public health. And I belong to a training school through my mentor, Dr. Ed Kilbourne at the CDC, and others as well at the ACMT and then the Georgia Poison Center, that really believe strongly that medical toxicologists are essential in the public health response system or the public health structure. So you are going to hear about all of these various aspects today in this program that we put together carefully. We are short on time a little bit. We are also going to be joined by the World Health Organization Center for Environmental Health Action from Jordan via webinar, as well as by a colleague from New York City, New York in the afternoon. So we will have some online juggling to do, but we already tested it out this morning, and I think it's going to work out. I want to thank our sponsors, Toxins, which is represented by Ms. Lucy Schiffelbein here, Randox, as well as Response System International, and Integral Global Consulting. Please make sure you stop by their booth and say hello to them and thank them for their support. Without any further ado, I would like to move on to the next, our first presentation by Dr. Edwin Kilbourne. Dr. Edwin Kilbourne is my mentor. I met him in 2003 when I joined the fellowship at CDC Emory Georgia Poison Center. Dr. Kilbourne is the one that really instilled in my heart the importance and love for public health and injury prevention. He taught me a lot of public health principles that I use every day in my practice and in my career. I've asked him to talk about his career, his journey. Dr. Kilbourne, before retiring in 2005 from the CDC, had spent around almost 25 years at the United States Centers for Disease Control and Prevention as a Public Health Service Corps member. He is probably the pioneer of clinical toxicologist in public health. And his career is illustrious and marked by several key investigations that he led that really prevented thousands of injuries and death. He is going to share with us today his experience. He's speaking today as an adjunct professor at Emory University Department of Emergency Medicine, although he also works currently with another company called Leidos. Dr. Kilbourne, thank you again for being here with us, and we look forward to your presentation.
Good morning. Ziad, I'm pleased to be here. I think we probably got more from you than we ever gave you. But that doesn't matter. I'm pleased to be here. I want to thank the sponsors, and I want to thank you in advance for your attention today. Dr. Kazi asked me to speak about my career, and I found that, at least as far as I'm concerned, I'm not so terribly interesting. Can I have the first slide, please? Oh, I do it. Who do I point it at?
There you go.
Okay. Right. You know, I've had unusual luck in an unusual period of time when public health was changing and the world was changing in a way that brought toxicology to the foreground. And I've had opportunities not available to everyone, and I think that's part of what I've been able. That's been an enabling factor to help me do what I want to do. But let us pay attention. I cannot speak about the development of toxicology, clinical toxicology, in all of the countries of this area of the world. And so I'll confine myself mostly to how clinical toxicology developed in the United States. Let's go to the next slide, please. Oh, I have the, sorry. Oh, my luck. The location and time, the US following World War II was a very vigorous economical economy. I was in the generation that's known as the baby boomers. There were a lot of children born after the war. My father was also a respected physician scientist. He worked in infectious disease and worked specifically on influenza vaccine. And I often think of him as issues come up these days with influenza and what he would have done and how interesting he would have found it. I had a couple of illnesses while a child that required specialty care, and I went into New York City from the suburbs of New Jersey frequently, and I came into contact with hospitals, and I found them to be fascinating places. I also went to my father's lab, and I think I was stimulated there. I had excellent mentorship, and I had excellent students, like Dr. Ziad Kazi. In the course of my career, I've been influenced by such people as Dr. Sir Richard Dahl, the well-known British epidemiologist who died in 2005, I'm sorry to say. Dr. Clark Heath, a famous cancer epidemiologist, Dr. Henry Falk, who discovered the link or had a major part in discovering the link between vinyl chloride and cancer. Dr. Stephen Thacker, who is well known at CDC. He died young, and various parts of the CDC are named after him. And as I said, I have had great students and people to work with me. Now, if you go through clinical medical toxicology in the United States, you find really that the first impetus for it occurred in the 1950s. And that was because the war stimulated, we were running low on latex, for instance. And so various forms of rubber were being tried. A substance called neoprene was developed instead of rubber for tires. But the chemical industry just went really forward in great leaps and bounds. By 10 to 15 years ago, the numbers of known and frequently used chemicals in industry was in the tens of thousands, close to 100,000. The number of compounds that had been synthesized, developed, or reported on was in the millions, 6 or 7 million. And the American Chemical Society has a registry by which they keep the numbers. So it becomes a very difficult field when people are being exposed to all sorts of things. And so it was with increasing complexity that pediatricians, particularly because children, well, I remember having very young children, they'll eat almost anything. And you can, and any poison center knows that. that so many of the calls are about children and what they ingest. Many of the more serious cases are related to adults because sometimes their motives are suicidal or towards self-harm. That's infrequent with the children, of course. In the 1950s, there were literally hundreds of poison control centers. It became a popular thing for every hospital or healthcare institution to have this as something that would make add luster to their prestige, add something. But there was really there was little, if any, quality control at that time. And there wasn't a process for evaluating. There was no certification. Also in the 1950s is when Dahl, who I think read medicine in the 1940s, started to get results from the British physicians study. And one of the things he looked at was smoking. And it started to come out that there was an association with lung cancer. Dahl's work was was pivotal in terms of the United States response. When Surgeon General Luther Terry made the announcement that lung cancer and smoking were associated. Of course, we know now that smoking tobacco is associated with many, many health conditions, but this is certainly one of them. So I believe it was for that and in his related work that he was knighted by the Queen of England. 1958, people started to be concerned with cancer, and there was some legislation which was not given great importance at the time, but it was called the Delaney Clause, and it was added to a piece of legislation regarding our Food and Drug Administration, saying that the FDA could not allow any known carcinogens to be in food. So this is a time in the 1950s of many chemicals starting to realize the problems of chemicals and what they represented for public health. So the precise words, I believe, are the Secretary of the Food and Drug Administration. That is odd because it's called the Commissioner of Food and Drugs, but perhaps that came later. Shall not approve for use in food any chemical additive found to induce cancer in humans or after tests found to induce cancer in animals. The problem with that is that as chemistry progressed, it's hard to say, it became harder and harder to say that there was nothing, not a single molecule of a carcinogen in food. If you think about it, foods are very, very diverse group of chemical substances. And so to swear about that, you have to be a very, very good chemist. You can't actually swear that I have not put in anything that is chemically a problem. So as chemistry became better in response to the synthesis of new chemicals, we really didn't know, and it was hard to follow the Delaney Law. In United States jurisprudence, there is something called a de minimis exposure. De minimis means that it's such a small thing that we're not going to pay it any attention. And ultimately, that was a concept on which low-dose exposures were regulated, such that if you have a risk for some additive ingredient in food that is less than 1 in a million lifetime by estimates, or perhaps one in 100,000. That you might that could be called de minimis, meaning it's not big enough to worry about. And that is a legal concept. That is not a health concept. But we developed it into a whole new area of public health and medicine, in toxicology. So let's move along. We'll return to Delaney. Clinically, in the 1960s, poison centers and clinicians continued to struggle to treat an ever-growing spectrum of causes of intoxication. The chemical industry was off and running and was extremely successful. Pollution became a problem because there weren't definitions of pollutants, and there weren't clear-cut rules about who could dispose of what and where they could dispose it. The US government tried to assist, at least the clinical side of the equation, by providing sets of reference cards on particular toxicants. And these made their ways around. I talked with my colleague, Dr. Barry Rumack, who is old enough to have practiced during that time, and who told me that the cards were usually one set per hospital, that frequently the cards, they were meant to be easily replaced when they were lost, and they actually migrated to patients' charts, away from the set. People would mark them up and so forth. So public health had developed further by having fewer poison centers recognized as, they became recognized as a critical public health resource. But the problem of funding started to emerge, and it continues to this day in the United States. Dr. Rumack, I believe he made a great deal of money, but he managed to get consumer product data, including proprietary formulas, and to put them in a database, which became widely used as computers became available also in the 1960s, were available to medical toxicologists. Sorry, I'm just going to say next slide. Yes. The 70s, the same trends continued. Certification of clinical toxicologists became an issue, and I think the early, I guess what we call now the first board in the United States started to function, and Paul Wax and Chuck McKay are here. Is that approximately the right date? In the 60s, or was it the 70s? 60s, okay, good. In public health, our air in big cities had become so polluted that President Richard Nixon, who's a Republican, who's not, not typically the party that is seen as safeguarding the environment, actually created the EPA by an executive order, which was later confirmed by the Occupational Safety and Health Act, the OSH Act. Poison control consolidated even more into fewer but much better centers. And the quality control of poison centers became a concern and started to be addressed. U.S. public health agencies began to study with this began to have to deal with this Delaney concept. But it it was a difficult area. How much are you going to absorb? Well, in FDA, if you have medicine or food, USDA safeguards food, EPA, the environment, how much, if it's in the soil, how much dirt gets in people's mouths. There were really no data at that time to really help move that study along. That's since been addressed, but slowly. And CDC got into the act, especially with regard to Love Canal. The Love Canal incident changed the country. It led to legislation that created the so-called Superfund. In other words, a way to clean up some of these dumps where people had just left all sorts of chemicals without regard or any thought for future contamination, the likelihood of very toxic chemicals getting into groundwater, whether those chemicals were toxic or what. So in the 70s and beyond, risk assessment became an important area, mostly done with animal data, which of course raised the question of how similar humans are to animals. For instance, even in mammals, we don't all have the same organs. There's a distinct area of the mouse, I believe, called the forestomach. If the forestomach, which we don't have as humans, generates a tumor after exposure to a certain chemical, does that count? Does that make sense? How much is de minimis? And how do you estimate that from animal data? How do you even treat the animals? Animals with, such as mice, with I think a year and a half lifespans, rats with 2.5-year lifespans, how do they compare with a 70-year lifespan of a human being? The area of animal extrapolation, full of theory and not much data, became a very important concern. So that remains an issue and an area for study. Poison center quality remains an issue, but the American Association of Poison Control Centers has developed criteria to review poison control centers to see if they're adequately staffed and can provide information that's adequate to the public and to physicians or other healthcare professionals that come in. So that's an issue of which we should be proud, and we are proud because of the concerted effort of toxicologists. There are not very many of us that are clinical and see patients, but we're scattered throughout the country. But we come together and we make these kinds of decisions, and it's an important aspect of the way we function. Public health surveillance of intoxications began in a really meaningful way more in the late 1990s, the early 2000s, and continuing to this day. The Superfund legislation took a lot of money, and right now that is ratcheting down. On the other hand, the most severely contaminated sites have been addressed. They're not necessarily clean, but there are rules for disposing of hazardous waste now, and they're under the Resource Conservation and Recovery Act, as we call it, RCRA. It's not a word, it's just a bunch of letters. But those are the initials of that legislation. So let me conclude. Where we're going, both as clinicians and in terms of public health, is in a pathway that is coming together. When I got my certification in medical toxicology, I wondered if it was even appropriate, because I thought of medical toxicologists as seeing emergency patients. They're, the patient comes in, they're unconscious, the skin is wet, the skin is dry, the pupils are big, the pupils are small. What is the toxidrome? How do you think through this case? And that's not something I had been doing. I had been looking at outbreaks, and we'll talk more about outbreaks later in the week. And so I'm not going to address it a lot today, Ziad, I'm sorry. But also I see that my 20 minutes is up. So perhaps I should stop talking. But clearly what we do in public health affects what the clinicians do, and vice versa. I found that when I was in government, to work with Dr. Paul Wax, who I see over there, and others in the American College of Medical Toxicology was tremendously beneficial. And I think and I hope that when I served on the board that tests U.S. physicians for competence in toxicology, I did push, and Paul will remember this as well, for knowledge of public health and the importance of public health such that it's become embedded as part of our culture now, our professional culture. Anyway, I thank you for your attention. I look forward to seeing you later in the week. I'm pleased to be the lead-off speaker. My gosh.
That's a tough job.
It's an honor. Okay.
Thank you, Dr. Gilmore.
And I'd be pleased. I don't know most of you, but I'd be pleased to meet you as we go through the week, and thank you very much.
Thank you, Dr. Gilmore. As well as fellowship trained in clinical toxicology. He's a regular supporter and staunch supporter of Minatox, and is going to talk to us a little bit today about the poison centers, the U.S. model for poison centers and public health.
Good morning, everyone. It is an honor once again to be with you and participating in this great conference. Dr. Kazi has been very instrumental in getting me involved in these conferences, and today I'm going to be speaking about the involvement of poison centers in public health. As you heard from Dr. Kilbourne, it started with physicians who were very much involved in identifying public health concerns, and then it was the role of poison centers to execute on some of these. Now, I've been blessed that I've been part of an organization that has been very much integrated into public health. And so as soon as I get my slides rolling, will it show up on this screen? No. Okay. So I've been very fortunate that the program that I work for has been very much involved in public health. And so just a little bit about me. You heard Dr. Kazi talk a little bit about me, but I am trained in pharmacy at the University of California. I went ahead and did extra training in toxicology, and I have been working in the same poison center since the late 80s. So with 32 years of experience, I've been able to see our program develop. Now, just to let you know, I don't have any conflicts, but if you're unaware of where Atlanta, Georgia is, this is where I am based, is in Atlanta, Georgia, and my state is one that is, it has over 10.5 million people. we were a brainchild of a pediatrician. You heard Dr. Kilborn talk about pediatrics being the primary patient pool, and it was very much that that a pediatrician wanted to figure out a way to get information to his residents, because these were the most common poison cases that we were getting. The key for us was in the mid-'80s, where our health department, public health, said poisonings are a public health concern. It was one of the very few poison centers early on that had an established relationship with public health. And so with public health recognizing that this is a concern, the health department not only designated us, but they also started giving us money. You heard Dr. Kilborn talk about money as being an issue, and when you're talking about hundreds of poison centers that started when this whole program began, now we are down to just a very small few poison centers, and I'll show you those numbers in just a bit. So in my particular poison center, you know, we've grown tremendously since I've started. And so just a little bit about us. We're one of now only 55 across the United States. At a time when the early 70s saw poison centers proliferate, just in my state alone, there were over 200 people that called themselves poison centers in the state of Georgia. But the state public health recognized we need to centralize these programs and designate only one center to cover our entire state. The staff that we have consists of nurses, pharmacists, and physicians. And when you talk about the kind of call volume that we have, nationally across our country, over 2.5 million poison exposures have been reported and collected. And in Georgia alone, we are recognized as the second busiest poison center in all of the United States. So up to 350 human exposures are called into my center alone. A good majority of those, nearly 9 out of every 10 calls, comes from the average person, not a healthcare professional. And certainly the ones that are, the cases that are most difficult are the ones that we get from healthcare professionals. The data has changed fairly dramatically over the last 30 years in terms of the call pool that we get. You heard about pediatrics being the primary pool. In 1988, when I got here, about 65% of our calls were about pediatrics. Now, that has decreased significantly to 50%. Can someone tell me why the pediatric exposure volume has gone down? I'll give you the answer in 2 words. Dr. Google. The reason why volume has decreased is the proliferation of the internet. I mean, you could treat everything from broken bones to poisonings now. So people are less apt to call us. Therefore, you see the decline in the numbers of cases that we get. As I tell my population in Georgia when I'm lecturing, I try to promote the poison center services because I ask them, would you rather trust an algorithm or would you rather talk to a healthcare professional? What do you think is going to be most beneficial to you? So well, yeah, and Alexa and Siri, you know, they could, you know, they're not as good as the people who are, you know, familiar with the most up-to-date data, using the most up-to-date resources, whether it's toxins or micromedics. Trying to convince them that a human is much better is difficult. And even when you tell them it's a free service, still someone wants to pick up their mobile and ask Siri if, you know, silica gel is a problem. So it's something that our generation now has to deal with because we've become so enamored with quick answers and bullet points, oftentimes the conversations about poisoning just don't happen. And that's why we're seeing such a decline in the number of cases that we're getting about pediatrics. They are still happening. Don't get me wrong. Pediatric poisonings are still happening. But people love their Google. So what are we getting called about? Well, this should be familiar to you, because across most of the U.S. poison centers, their data is going to look fairly the same, but analgesics obviously are at the top of our list, all the way down to foreign bodies and pesticides in terms of the calls that we get here in our office. Now, the striking fact that makes us such an incredible public resource is our ability to handle these cases and keep a majority of these cases at home. This is where our money is, in preventing the unnecessary visits to doctor's offices and to emergency rooms. So when you think about the cost savings, yes, public health is investing in us, but their return on their investment is tremendous. And that's why when our state realized that in terms of the cost sharing of Medicaid and Medicare, giving us a little bit of money will result in tremendous cost savings. And the insight and think about this, this is the early 80s where public health said this is an important program to have. What's really disappointing and disheartening is that in the 80s, we were one of the very few poison centers, if there were even any, that were integrated with public health. If you fast forward to 2020, the numbers are not very much better. What is the primary reason why some of the people in public health don't integrate with their poison centers? Everybody claims poverty. Everybody claims poverty. And of course, as you look at everything from the CDC budget being cut to other poison centers' budgets being cut, our state has remained steadfast in saying poisonings are a public health concern. This is an important project for us. We're going to continue to fund. That doesn't mean I'm waking up every day and happy with my funding. In fact, before I came to Turkey, I was alerted that I was going to be cut about 15% of my budget. And I am pleased to tell you that while I was visiting a palace yesterday, I got a text message that said for this year, our money was restored. That's right. People who write the laws recognize that, you know what, being penny wise and pound foolish, cutting our budget would result in far more millions of dollars. They wanted to cut us hundreds of thousands of dollars, but yet the cost to them would have been millions of dollars. And finally we got, after a couple of communications with state public lawmakers, they realized this was a very foolish decision to cut our money. But not everyone is successful as us. And so we've been lucky that we've been able to convince state public health that we need to be funded at the levels we're being funded. So when you look at the collaboration, as I said, I've been part of the program for over 30 years. We've been integrated with public health since before I got here. When we first started with public health, nobody else in the country was doing this, and we were managing animal bites and rabies. We were the depot for getting cases about foodborne illness. We were being asked to provide information in major public events, and I'll be talking about some of those in just a second. And then also, they wanted us to be able to provide a 24-hour hotline for people in our state that had other public health concerns, and you'll see some of those in just a second. So they recognize that poisoning is a public health concern, whether it was environmental, whether it was occupational, whether it was in drinking water. They recognize that if they provide the public with a resource to call for information, number one, their jobs would be made easier, so their phone lines wouldn't be filled. And then they chose us because we're a 24-hour resource with medical professionals. So we established programs here that I'm demonstrating here, and I'm going to go into these more in depth because, for example, a poison center and its ability to handle cases regarding hurricanes, does that even make sense? You think maybe it's just medical, maybe it's just, you know, an antihistamine overdose or a cardiovascular. Why is our poison center involved in H1N1? Why is our poison center involved in the latest coronavirus? These are all public health issues, not poisoning issues, yet they're coming to my center and saying, we need help, and can you provide it? So let's talk about some of these here. For example, rabies. Back in the 80s, they asked us to work with them to provide care about animal bites. And one of the things that I tell people when I'm lecturing, here's the beauty of rabies. If you get bitten by a rabid animal and you start having symptoms, I tell my audience, there's only about 100% chance you're going to die. Only about 100. But the need for medicine, the need for rabies prophylaxis, the need for the antidote is importantly held, and the decision-making should be held by people who are more knowledgeable. Instead of just giving everybody the antidote, even though it's 100% fatal, you need to be able to have a program that identifies those patients at high risk. You need to be able to do it in a manner very quick, and you need to be able to do it on a 24-hour basis. We were that organization. And in the early 80s, unlike the other colleagues in poison centers, nobody had a program. If they did, there was probably less than 3 or 4 of us that had an active program that managed animal bites. Looking at the cost savings, just in making the recommendations or not for rabies antidote, resulted in a cost savings of over, $5-7 million. And just for funding us for a few million, you save 7. Hey, who wouldn't want to invest 1 million, and every year you get 7 million? Get in line with me, because if you have that money, we can make this kind of cost savings, right? What's another program that the state said, can you help us with? Well, there's a program that's a federal program that individual states are able to take part in, and that is the strategy of locating certain depots of antidote in strategic areas in the state in the event there's an exposure, a mass exposure to organophosphate poisoning. So the federal government gives the state quantities of organophosphate combating agents, and the poison center is the gateway to be able to utilize these resources. We know the secret of where all these antidotes are stashed throughout our state, and when a mass occurrence happens, whether it's a truck that overturns or where there was a spill at a factory and it involves nerve agents, we have the ability to identify where the closest resources are. We have the ability to then release this antidote for use. One of the other things that we do is for our state, we provide our state the number of 1866 Pub Health, and you see the number spelled out there, but we have separate call center staff who answer certain public health questions, ranging from notifiable diseases, bioterrorism events, and other public health emergencies. And these are people that are utilizing the call center capabilities, and we're able to do this on a 24-hour basis. Now, who are the folks that call us on this special hotline that's contained inside the poison center? You see everyone from healthcare providers, pharmacies. We get calls from the quarantine office at our airport, veterinarians, a number of agencies, but the primary call base is going to be people who come from just the general public. Now, the thing about our hotline, our separate hotline, is this is a way for people to talk to us about everything from diseases, dead birds, mold, if there are feces in swimming pools. Where do people turn to when they need information? Who are they going to call? The state said, can you handle everything, like these, like restaurant complaints, mosquito complaints, hotel, food complaints? All those calls come into the Poison Center. So again, it's resources the state says, hey, we can provide it to our residents of Georgia. We could do it on a 24-hour basis. Now, the unique thing about these calls is we document these calls, and these calls immediately get uploaded into the state public health database. So there's no duplication of effort. A public health call comes in, we enter it into our system, our electronic medical records, and every 10 minutes, these cases automatically get uploaded to public health so that they see cases in real time. Now, those hotlines that I talked about, we know the clinical side of this. Acetaminophen overdoses, aspirin overdoses, calcium channel blocker overdoses. Those of us who are toxicologists know these are the routine things. But remember, we're talking about public health today. We're talking about the bridges of public health and poison centers. These are not traditional things that poison centers do. As I mentioned, we are dealing with cases that involve pandemics, endemics, hurricanes, disease monitoring, mass messaging. What are some of the examples? Well, I mentioned in 2005, the state said, can you help us with hurricane victims? Not from a toxicology standpoint, but from a resource management standpoint. People from Louisiana were forced to go to our state, but they had no idea about housing information, medical information, food, people who needed glasses, everything like that. The state said, we need your assistance, and we think you could do it. Why? Because we had the infrastructure. We had a call center. We had an electronic medical record. We had a way to answer calls on a 24-hour basis. And so we partnered with Georgia Department of Public Health to provide these resources to the people who were coming to our state. This is not a poison center function, but the state says, we need your help. You are a public health arm. You are an arm for public health and public information. Can you do this? So we hired extra people. Within 2 days, I was able to train staff, and we were able to use our infrastructure and be able to deliver this program. What other things have we done on a mass scale? Well, we've been fortunate that we've had major events in our state. Those events include the Super Bowls, those of you who are football fans, 1994, 2000, 2019, and of course, the big event that we had to prepare for because of public health was the Olympics. In 1996, the Olympics came to Atlanta, but it was in 1992 that we were awarded the Olympics. And from 1992 to 1996, we were working nonstop to be able to provide certain public health information to the people who came to the state. Now, primarily, we were looking at bioterrorism events, and so we all got fairly familiar with anthrax and nerve gas, and so we were ready to provide that information, and I'm going to share with you the mechanism that we were looking to use to do that. So, when you look at pandemics and such, in 2009, the state asked us, Dr. Lopez, can you provide a call center for people who have questions about H1N1? Again, this is not a poisoning, but they wanted to use our infrastructure of healthcare professionals who could work in a call center around the clock. And so they gave us a little bit of money that they would never be able to use to spend to develop a program, but they knew they could use our infrastructure and be able to do and deliver these programs immediately. We started not only with H1N1, but we've done work in Ebola and Zika. Again, a poison center and infectious disease. You don't think these are partners, but we are in bed all the time. And lately, our latest project is working with the state on the novel coronavirus. Again, what is our role? We have been asked to take monitoring capabilities, meaning monitoring temperatures, monitoring symptoms, not a poisoning, but a valuable public health resource. So when the patients arrive at Atlanta Airport, they are told to call a certain number. They don't know they're calling the poison center. They know they're calling public health. And so again, we feel, honored to be able to help in these particular events. The one that happened that was a public health emergency happened just a couple years ago. We were in the news across the United States. You might have heard it, in your country, but with the opioid crisis that we're experiencing, there was an incident that occurred while I was on call where at 10 o'clock at night, a doctor calls me and calls our center about how can we alert the public about an event that's happening in my area, and over the course of the last 24 hours, we are recognizing that there's something unusual going on. Can you help spread the word that we possibly have an epidemic in our state? Because in the last 24 hours, 5 patients have presented very similarly where they have needed high-dose naloxone because of severe respiratory issues, all after getting drugs on the street, all having taken only 1 pill. We later find out that this exposure involved purchasing off of, in a drug house. A small amount resulted in major problems, and our cases were being fed electronically into our system, and hospital data later confirmed in a syndromic surveillance study that there was something in fact going on. But who was the first agency to recognize it? It was the Poison Center. Now this is a case where we're talking about poisoning now with a public health event. And so we were able to document a number of these cases. Our state public health director, our head person in public health said, hospitals in Georgia, starting now, anybody who meets patient criteria must be referred to the Poison Center. They must be able to report these incidents to the state Poison Center so that we could track these patients. So over 2 weeks, we identified almost 30 cases, and a number of these folks, you could see here the statistics on these individuals, and you could see that they all presented fairly similarly. When all was said and done, we understood all these patients were looking to buy Percocet, and when they ended up taking these Percocet, they almost died. In fact, 5 individuals died of the 27. We later identified this as cyclopropyl fentanyl, not Percocet, and it also had another novel opioid, and we were able to immediately work with public health and our partners, our Department of Public Health, GBI, and other law enforcement. It's all because of how that call ended up coming to the Poison Center. Now, another program that we use that allows us to talk to people and multiples of people is using this problem called SUFER, and it stands for Surge Public Health Emergency Response System. What is that? In short, what it is a phone system that overlays on top of our existing phone system to allow us to simultaneously receive calls of from nearly 600 people at the same time. Now, we don't have 600 agents in our office, but you're able to develop messages that the public could hear regarding an event. So we used our existing infrastructure, we put messaging into the system, and it was a text-to-voice program where you put in the most common frequently asked questions and answers, and the public goes in and they make a call to the number, they enter their code of their county, they select a message, and if they're satisfied with the message, we've done part of our job. If they're not satisfied with the message, then they're able to find someone who is a live agent who can speak. So, in summary, it is an incredible relationship that we have with public health. As I mentioned at the very beginning, many of our other partners throughout the United States don't have this relationship. They don't have the luxury of being able to work with other public health agencies. And when you think about our collaborations, they've recognized that at least our Poison Center is an efficient way and a cost-effective way to deliver public information. We are always surprised to hear why other poison centers don't have the same relationship. But slowly but surely, I think public health is recognizing the importance of having a poison center, helping them with these kind of situations. And for us, I've been lucky to be part of a program that for over 30 years has been partnered with public health to not only provide poison information and treatment information, but also to provide valuable information for the public health in a variety of areas. It doesn't matter if it's bioterrorism, it doesn't matter if they're worried about mold or a dead bird, or of course now some of the pandemics we're seeing. We've been involved in H1N1, Ebola, Zika. We got called about, now we're doing so many things with the novel coronavirus. These are non-traditional things that we are doing, and we've been very fortunate that public health continues to support us. And yes, I will continue to fight for money that they take away from me. I will continue to tell them that if you cut me a little, we're gonna cut some of the programs to you a lot. And when they realize the people who push pencils, the lawmakers who write the laws, it's easy on paper to say, well, cut Dr. Kilburn's program by 10%. We have to achieve a bottom line. We realize that people do listen to us. We realize that lawmakers, know that the Poison Center helps us. And I've been very fortunate that I work for a program that integrates with public health very intimately. Thank you very much.
Dr. Lopez, thank you. Any questions? The center is unique because it also contributes a very important toxicology resource for the world, an information resource called toxins. And oh, you are okay. Sounds good. So Gaylord is still on stage, and then we are going to look at the poisoning emergency from the scene to the Poison Center and beyond. And what they want to do here is they want to share with you various stages of Poison Center involvement with paramedics, with the hospital, etc., and how they are able to assist along the way.
Okay, so I'm going to open quickly on, again, poisoning is a public health issue. Both Lucy and I will be talking about what happens from the scene to eventually when you get seen. Because those of us who are in a poison center model where we have our poison specialists working primarily to provide information as opposed to physicians who do it from start to finish, we're going to share with you a few cases where our poison specialists are the ones who are managing these very critically ill patients. And so, just as a reminder, my state is populated with 10.5 million people. The Poison Center is staffed with this kind of organization. We have poison specialists. We have 19 full-time people. We have computer people. We have trainers. We have residents. We have fellows. We are probably the most best staffed group of toxicologists in all of the United States, with our resources at Georgia along with our resources with the CDC. The staff that primarily handles the emergencies are nurses, pharmacists, or physicians. So those are the people who work in our call center. And these are folks handling the calls on a daily basis. Now, I'm going to go over 4 cases really quickly, cases that we get on a day, very commonly, and it starts with these routine cases that our folks handle. So let's take case number 1, where we have a pharmacist who's calling the Poison Center for information. So the pharmacist is calling us about a 4-year-old patient who gets 4 tablets of iron pills. Now, what the mother is asking not the Poison Center, but the mother is asking her pharmacist for advice. Now, what I would have preferred the pharmacist to do is tell the mom to call the Poison Center, but instead he calls us. Okay, so that's not uncommon, but the pharmacist doesn't know what to do because they're not trained. So they call us, and we take history. And so we put the pharmacist on hold, and what do? What is our next step? Well, I've been at these conferences, and we've talked about the development of guidelines so that your staff can do the majority of work for you. So we have a guideline on our internal internet that allows us to look for cases that have specific protocols, specific actions you take. And when you go to our protocol book, you'll find that we do have a guideline on how to handle iron ingestions. So our poison specialist says, hey, let me read the protocol. Let me see what has to be done. And when you read the protocol, you'll realize that for pediatric patients, we have a guideline of how much they could take without having to go into the hospital. So when you figure out that you could do calculations and realize that your patient did not get enough iron, you do your simple calculation. This is a case where we performed a calculation. We recognize it as being not a problem, being subtoxic. We decided to do an additional call 4 hours after they got a hold of us, and we realized the patient only had minor effects, maybe some nausea and some vomiting, and then we decided to keep the patient at home, and we closed the case. Very cost-effective way, and think about how much an emergency room visit would cost if this patient went directly to the hospital. Think about how much cost it would be if they just went to their pediatrician. And think about the time that it would take to do all this. The Poison Center, a public health partner, said we can do this, we could keep them at home, and these are one of the 85% of cases we keep at home. What about case number 2? A dad tells us that his 3-year-old son just had awoken from a nap. He took a nap for 5 hours, and when the child wakes up, he tells his father that he ingested a penny. And so, again, a poison center is in place. The father recognizing that there is a resource for me to call instead of immediately going into the emergency room. He calls Poison Center. Now, for those physicians in the room, some of you are probably saying, oh, it's probably nothing, just leave it at home. Well, in order for us to make a decision, we turn to our guidelines again. Do I have a guideline on foreign bodies? And we take history, we look at our computer system, and wouldn't you know it, we have a guideline on foreign bodies and choking hazards. So our poison specialist goes into the guidelines and they read what is our medical backup wanting us to do in the event of foreign bodies. So again, this is not a case being handled by the medical toxicologist. This is a case being handled by the poison specialist who has direction from the medical toxicologist because we have a guideline written and approved by our medical toxicologist. Now, because our protocol advises that that patient needs to be seen, we want to make sure that the penny is beyond the esophagus. So how do we do that? You can't do that at home. You must take x-ray. So we were able to send to the hospital, they performed a abdominal x-ray, and they did isolate and find that the penny was in fact beyond the esophagus into the intestines, and the patient was now safely able to be discharged. Again, by following our guidelines, we were able to manage this case appropriately, tell the hospital in this case what has to be done. In fact, one of the key elements that we do is if we recognize a patient has to go in, we will call the hospital ahead of time and tell them a 3-year-old patient's coming in, this is what you have to do, this is what you have to monitor, so there'll be no waste of time. So again, it's by use of guidelines. The third case I want to talk about, mom, I told you about this earlier, decides to consult Dr. Google. So she's Googling what happens when you ingest Visine. Everyone's familiar with Visine, the eye drops, if you have red eyes, right? So now the internet tells her this is a major problem. This is an issue. The mom's not sure what has to be done, but she tells us that the ingestion is not witnessed, and the kid is a little drowsy, but it may be nap time. So now the mom says, I read Dr. Google. It sounds like it's a problem, but let me talk to a real person. So she calls us, and after we take a history, we want to look up if we have a guideline. And wouldn't you know it? We have another guideline. We have a guideline for imidazoline compounds and vasoconstrictors. And when you look at our guideline, you'll notice that we have a specific protocol that if you have this ingestion, these symptoms, you must be evaluated. Again, these are written by the medical staff, Dr. Kazi, Dr. Geller, Dr. Morgan. These are the physicians who write these guidelines so that the staff has directions on what to do. It's not cases that you have to deal with on a minute-by-minute basis. Many poison centers have these guidelines, and they are basically instructions on what to do in the event of a particular type of exposure. As per our guidelines, we noted that the child had to be referred into the hospital. We went ahead again and called the hospital to say that little Johnny is coming in. This is the poison center. This is what can occur in this particular overdose. These are my steps that I want you to take, and these are the things you need to look for. The child gets to the hospital fairly quickly, within 20 minutes, and the child is noted to be altered, is noted to be somewhat CNS depressed. We follow up with an additional calls to the hospital. After the child is admitted, we follow up. Our protocol calls for continued follow-up of these patients, and we do 2 more, and we realize that the child is fine after 24 hours. Boom, 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 they go home. And because the hospital is waiting for our specific recommendations, they will follow our directions. In this case, the outcome was good. Now, the last case that I have is the following. We have a 20-year-old patient, a female, who calls us and says, can 1/2 bottle of insulin, if I inject 1/2 bottle, I hope I will be able to die. That's what she was asking. And she's asking because she wants to make sure she dies from the insulin. Why? Because she's tired of always being admitted to the psych ward. She now is tired of her life, So this is an unusual call for us where someone says, did I do enough to kill myself? So you might be thinking, well, how do you handle a call like this? You could go to your resources. That's what we did. You could go to the databases. That's what we did. But I want to share with you what steps we took. So we asked the patient to go into the hospital immediately. And for many cases, they simply don't follow our recommendations. Now, when we called the hospital, we advised them early what they have to do to treat this patient. Now, one of the things that we, as part of our protocol, for anybody who we referred to go into the hospital, we always called the home back within 1 hour after they call us to make sure they followed our recommendation. So, number one, we called the hospital and we told them patient X is coming. Within an hour, the hospital didn't call us back. We realized the patient may not have gone to the hospital. So we called the home and there was no answer. But how are we guided with a case like this? Because it's a situation that's life-threatening, guess what? We have a guideline. We have a protocol. What are the cases when you need to call a medical toxicologist? When is it that it's important for the poison specialist to seek extra help in managing a case that may be difficult? We have a protocol for it. So, we have a protocol here. Within 45 minutes of a call, I told you that part of our procedure is we tell you to go in. Part of our procedure is if you don't arrive at the hospital, we're going to call you back to see if you left, if you're following our directions. Over the next 2 days, our office calls the hospital to give them further instructions. On admission, 2 hours after the initial call, the hospital calls us, the patient in fact arrived. Voila, this is good news. The patient arrives, they have a blood glucose of 22, so they immediately, initiate therapy, D50, D10, IV glucose, and then they're calling the poison center for more advice on what to do. They're waiting for us to tell them if there are other complications with so much of this product being exposed. Our job was to help with hand-holding of managing this patient. Over 2 days, we called 5 additional times to make sure everything was good. And our last follow-up on day 3, the patient was deemed medically stable and now transferred to psychiatry, which she doesn't want in the first place. So it just represents for you, at least for us, the steps that we have to take in order to manage these cases. And my colleague will present a much more complicated case that will dive into managing poisonings and the amount of work that goes into handling a very serious case. So I'll turn over the podium to my colleague, and then after the presentation, we would be open to answering any questions.
Dr. Hamoudi, question? You go ahead. Click on it.
First one, can we take a copy of this guideline management to my center in order to update our knowledge about?
So the question is, we have guidelines, we have protocols.
Can you send us a copy?
So I will answer it in the best way I can. The guidelines are written by our doctors who evaluate literature. Now, a lot of physicians in the room today, when they read an article, they may not see the same things I see. So these guidelines were written by people who know the literature, and they decide on their own actions they would take, because our poison specialist, myself, we work under the umbrella of the medical toxicologist.
Yeah,
right?
yeah, I know.
So, now, to answer your question as best I can share with you our protocols. Now, you could follow them if you like.
Yeah, yeah,
If you trust us, you could follow them. But I would be open to
Yeah.
sharing some of these protocols.
Yeah, if it is available in a software, it would be easy as to get an access, but not an internet access, because the internet services in my country is not so good.
Yeah, so
if you
for
have
us,
a software, this is the first
look,
question.
these are all contained within our own internal internet, right? So we have easy access. We could talk after the presentation about specifically how you might want to evaluate our data, look at our data, and maybe use it in your setting. We could talk afterwards.
Okay.
Okay?
Thanks. The second question about the financial funding of these numbers of calls, because no one in my country might fund or pay for these calls. How would you manage it?
So funding is a very tricky problem. Some of us get state funding, some of us get federal funding, some of us get no state funding. Since the early 80s, Georgia has recognized this is a public health concern. So we had insightful leaders in public health. That's what it takes. I have a fellow who just graduated from my program. She went to a state with no public health money, no public health relationship. Her job is to establish a relationship with the leaders in public health, and I'm understanding she's making some progress, even though she's only been on the job for 2 months. So you have to make progress talking to the people in public health. It doesn't happen just by magic. And we could talk more about some of our strategies.
Okay, thanks a lot.
Thank you, Hamoudi. For the sake of time, we're going to move on. That's great. That's okay. Thank you.
Thank you. So I'm going to follow on. I've got a bit of a complex case that I'm going to present. But first of all, there we go. Okay. So first of all, I just want to say I've got no direct conflicts, but I would like to disclose that I am also the manager of Toxins, Poisons Information, who are sponsoring this conference. So I just want to be clear about that. So, as you know, I'm from the New Zealand Poison Centre, and there's a wee photograph of the green building where our poison centre is housed. And for those of you that haven't been to New Zealand, you should come visit us. So I'd just like to say that Dr. Kazi's title for this stream, Bridges Between Clinical Toxicology and Public Health, I think is absolutely perfect. How are bridges built? Bridges are built using struts. One strut on its own cannot support a bridge. So a strut essentially provides outward-facing support. So if you look at that, we are essentially all struts on that bridge. So I just want to talk a bit about when a poisoning occurs, who gets involved? And why is it important to all be on the same page? And how do you ensure the best care and outcome for the patient? So you look here, poisoning is a bit of a puzzle sometimes, and there are multiple people involved. And that can be everything from the caller or the patient themselves, the caller's family, spies who take the initial call, medical toxicologist who becomes involved to consult, paramedics, the ED doctors, the ICU consultants, and then finally mental health or public health. So looking at a typical scenario, we have a person who calls the poison centre. So that's one call. They talk to the spy. That spy then advises them to call an ambulance. The caller then makes a second call, talks to ambulance. Ambulance calls back the poison centre to get advice. So how many calls are we up to so far? 3? The ambulance then transports the patient to the emergency department. At the emergency department, the staff then call the poison centre back for further information. Then the emergency department will hand over to ICU. So we have multiple conversations going on here about the one case. Are we all speaking the same language? Are we all doing the same course of treatment? It's very important that we are. ICU then potentially calls back the poison centre to talk to the medical toxicologist for further guidance. And then finally, if mental health are involved or public health, potentially they're also calling the poison centre. So if you look at all of those calls or conversations, they all add up to support that one case. So how do we record this? We were talking before about funding, and we know that funding is very difficult. If you underreport calls, you're not doing your job, so potentially you could lose funding because you're not seen as taking enough phone calls and providing enough support. If you overreport a case, you could end up with sending public health into a tailspin because they think the situation is actually a lot worse. There's more poisonings happening than there are. So it's really important that we record calls and record them accurately. So just looking quickly at calls versus events versus exposures, they're actually all very different things. And as you can see there in the middle, I failed art class at school because I can't draw people. So typically, about 80% of our calls will be one phone call involving one patient and one substance. Generally, they're pretty straightforward. So it's typically mum calling the poison centre about their child who has ingested paracetamol. Very easy, no further involvement, one exposure. You can have one call involving multiple patients and one substance. So again, mum phones up, both her children got into the paracetamol. So again, one call, multiple patients, but still just one substance. You can have multiple calls involving one patient and one substance. So we talk to mum goes to the hospital, then the hospital phones us. Still only one event, but it's 2 phone calls. You can have multiple calls involving one patient and multiple substances, and multiple calls with multiple patients and multiple substances. So for example, some sort of public health emergency, a chemical spill, there's going to be a lot of phone calls backwards and forwards to the poison centre about a large number of patients and potentially, several chemicals involved. Again, how do you record that accurately? So just going back through, so one call, one patient, one substance will be put down as one exposure. One call, 3 patients, one substance would be 3 exposures, but still just one phone call. 2 calls, 1 patient, 1 substance, 2 phone calls, but only 1 exposure. See, it gets confusing? 2 calls, 1 patient, 6 substances will be 2 calls, but 6 exposures. And then, for example, if we had 4 calls involving 2 patients and 2 substances, that would be recorded as 4 calls, but 4 exposures. So just looking at this case that I just want to walk you through and the calls and the conversations that were involved. Got a 37-year-old male attempted suicide by ingesting Cilazapril and aspirin. Quantities of both drugs were unknown, and the male is a type 2 diabetic. So the first conversation, day 1 of the exposure. His distressed partner calls the poison centre. She calls in a distressed state, tell us about the suicide attempt that happened last evening. She thought her partner would be okay, but he's just had a seizure which lasted 30 minutes. What's the advice? So we look up our protocols for Cilazapril and for aspirin. And in this case, for an acute on chronic dose of Cilazapril, medical observation is recommended for ingestions of 5 times the patient's usual single dose. Well, we don't know how much he took, so that's an uncertainty. Symptomatic cases are all referred. We know he's symptomatic because he had a seizure, so that ticks the box. And exposures with intent of self-harm, well, we know it was a suicide attempt, so that was another reason for sending him in. Second conversation in this case. The stressed woman has to ring the ambulance because of his symptoms, and he's just had a seizure. Our advice is to talk to ambulance direct. That way, if he deteriorates while he's on the call, they can guide her through CPR, etc. Conversation number 3 in this case. Ambulance then call back the poison centre. So they've talked to the woman, they're now transporting the patient, they want to know what to look out for en route. So again, we look at some advice and give some basic monitoring advice, looking at things like blood pressure, heart rate, level of consciousness, and perhaps putting a line in to get some fluids in. Conversation number 4. Ambulance has now arrived at the hospital, handing over to the emergency department staff. So they're going to talk through what they've found, their observations, and the advice that the poison centre gave them. Conversation number 5. Emergency department then ring back the poison centre for treatment advice. So the information provided to the poison centre by the ED physician is the patient has just arrived, so all they've done is vitals and blood gas at this point, and they've not started any therapies. They can't really do it. Well, they can do a salicylate test, but it's sent out, so the results aren't going to be back on time. Vitals are all over the show, and the patient has a history of poorly controlled type 2 diabetes. And glucose is currently at 53, and we know he's had a seizure. pH 7.23, lactate 12.2, sodium 129, and he's had a chest x-ray which shows possible pulmonary edema. So that's the information fed back to the poison centre. So based on that information, we do an assessment and we'll give some advice back. So our advice was ICU admission. Given that they weren't going to be able to do meaningful salicylate levels, in cases like that, if we can't get a result back on time, we always look at worst case scenario and treat for worst case scenario. It was advised to start hemodialysis, and there was some caution advised if the patient needed to be intubated. And again, the last thing we always say is call back the poison centre for that advice. The poison centre is kind of a central cog in the wheel and the keeper of the information. So we've had conversations with that many people, we know what's been said to each person. If these conversations were happening outside the poison centre, we can't coordinate the care plan. Conversation number 6. We now have the ED staff handing over to ICU. So again, they're going through all their observations and their treatment recommendations. So I'm not going to go through all those, but that's the numbers that the patient presented with by the time they got to ICU. So they're pretty poorly. So now ICU staff have had a further conversation with the man's partner, and it was revealed that diltiazem, not cilazapril, was involved in the ingestion. So suddenly we had to rethink what was going on here. It's now a different drug to what we thought was happening. So we're now up to day 2 of this man's care, and we're up to conversation number 7. So the ICU staff call back the poison centre and disclose that they're now dealing with a diltiazem overdose. So again, looking at diltiazem and our treatment guidelines, the first thing you'll see is consultation with medical toxicologist through a poison centre is advised, because this toxicity can be life-threatening. So it's right there, first thing we say, call the poison centre for a discussion. So an update from the ICU at this point, GCS 15, pH now 7.2, 26, lactate 9.7, no other updates compared to the previous call. Advice from the poison centre, it was to start or continue hemodialysis, monitor for onset of bradycardia, hypertension for diltiazem toxicity, and again, keep the poison centre involved and tell us what the progress is. A few days later, so the ICU have been supporting this patient for several days now. We're now up to day 6 of his care, and we're now up to conversation number 8 involving the poison centre. So high-dose insulin has been stopped, but patient's still receiving adrenaline. Patient is deteriorating pretty badly, and they've developed slow atrial fibrillation. At this point, their neurological exam had worsened. One of the things that was not clear was the symptoms of CNS depression were not in line with what we thought he had taken. Let's just skip through this. So at this stage, there was concern for brain death. The patient was too unstable to move to MRI. Every time they tried to move him, his vital signs dropped. So discussing the history that there were known drugs that should cause significant CNS depressive effects that would mimic brain death, we advised to check medication history again, just in case there was anything that had been overlooked or missed. Turns out that there was some colchicine tablets missing, but again, that didn't fit the profile of what we were seeing. But it highlights the importance of getting a really clear history and knowing what else could be going on here. At this stage, a family meeting was planned, and any further care and support was withdrawn, and unfortunately, the patient did pass away. So we've got one case, 8 conversations, and 7 very, very long days. It gets complicated. So how is this recorded for public health? Most poison centres have a due diligence to report to their funders or to public health to advise them of events that are happening for funding reasons, but also for surveillance. So it's important to get this accurate. So this was one event involving one patient with 2 substances, and even though there was 8 conversations, there were 5 phone calls. So you see the difference between phone calls and events. If you under-report or over-report, it can skew the numbers a bit. So basically, in order to achieve the best possible outcome for a patient, information needs to be consistent and flow freely. We all need to be on the same page to make sure that bridge does not collapse. And so from the initial call, from the scene, right through to hospital discharge and follow-up, the treatment needs to be consistent and have the same treatment plan.
Thank you for this nice description of your everyday work, which is a model to consider and follow in different parts of the MENA region. I would open this up for a couple of questions before we can go to the break. From the audience, if you need to speak, we have a microphone. Any questions? Everyone's ready for the break, I guess. Okay, so let's take it again, and let's go to the break and come back at 10:30. Please be on time because we have a webinar from Dr. Mazen Melkawi from WHO, EMRO, Center for Environmental Health Action from Amman, talking about the WHO efforts regarding poisonings in the region. Thank you. All right, psychology. It is my honor to present to you our next speaker from Amman, Jordan. Our next speaker from Amman, Jordan is Mr. Mazen Melkawi. Mr. Mazen Melkawi is the regional advisor for the WHO Center for Environmental Health Action. He is going to discuss with us a little bit about the regional framework on public health preparedness and response to chemical events for the purpose of the international health regulation implementation. He will share those remarks with us over 20 minutes. After that, we have rapid updates about various poison centers in the region from representatives from 5 poison centers. Each of those presentations will be a 10-minute presentation. And hopefully we'll finish on time for lunch lunch around noon. With no further delay, Mr. Melkawi, please go ahead and you can start your presentation. You can go through slideshow if you like, slideshow mode on your PowerPoint.
Good morning.
We can hear you good.
Okay. I'm glad to speak to you this morning, and I regret that I lost the opportunity of participating face-to-face to chat and discuss, issues of mutual collaboration with colleagues.
Mr. Melkawi, do you want to go on slideshow? You can go on slideshow mode. All right, very good. We can hear you well.
Oh, great. In this morning's session, I will be speaking a brief introduction on the international health regulation. I'll shed some light on chemical events and the joint external evaluations that we are doing jointly with the countries to determine their capacities of responding to chemical events. We did some analysis for the joint external evaluation mission, and last year actually we developed a plan of action, to help countries to respond to chemical events in the year 2018 and 22. International health regulations is an agreement between most of the countries of the world, 196 countries, including all WHO member states, to work together for global health security, actually, including events like biological and chemical and radiation hazards. The new thing about IHR, it does not just focus on infectious and non-infectious diseases.
This meeting is being recorded.
It focuses actually on the what we call the all hazard rather than specifying specific type of hazard. Through the IHR, countries agreed to build their capacity to detect, assess, and report public health events. And during the couple of slides, I'll show how this is very much linked, to the subject of your meeting. Within the IHR framework, or the multi-hazard dimension, there are 19 capacities or 19 things that are being discussed. And if you notice in red, the chemical event is one of the issues that I will focus on. One basic thing, you know it better than me, that the global understanding of the complexity of the health impact of chemicals is not as easy as we can imagine. The number of chemicals is on the rise. The latest estimate of WHO that 2.7% of the global deaths, about 1.6 million people, are dying because of exposure to chemicals. The chemical releases arising from technological incidents, natural disasters, conflicts, and terrorism, the man-made, are common. And during the 10 years from 2000 to 2009, about 3,200 chemical disasters, killing about 100,000 people and 1.5 million affected. But it is there, it is on the rise. A chemical event in one country can lead to health consequences in another. This is the main issue that we are concerned. There are a lot of examples where a chemical spill happens at a water river, and affects several countries. It is essential to talk that the IHR implementation is not just the responsibility of the Ministry of Health alone. And when we come to toxicology and poison centers, it's very clear that it's not necessarily the Ministry of Health alone. But the collaboration, that's a very good example, about an incident that happened in a factory on a water supply where several countries were affected. If we look at the number of unintentional chemical poisonings in the region, which is unfortunately a bit old estimate, in the region, about 8,400 people lost their lives actually because of toxicity. And we all know that registration of toxicity is not that bad. I would say the real number is much higher. In 2014, the countries of the region did what we call the self-assessment actually, and they identified the gaps in different aspects of IHR. In a sort of, I don't expect you to read, this, but these are the capacities that are linked to chemical events and preparedness. And if you see, the picture is, from a self-assessment, is good. It seems that green capacities are there, more or less a lot of green is in the screen, which means that the capacity is fair. But unfortunately, when we did the assessment jointly with the countries, the picture was a bit different. And in the joint external evaluation, actually, we are measuring two main indicators. The first indicator is mechanisms are established and functioning for detecting and responding to chemical events, and we give usually a score from 1 to 5. And the other one is that is there an enabling environment in place for the management of chemical events. Again, the scale is from 1 to 5. Yes? I'll continue. Capacity 1 means there is no capacity. Capacity 5 means that the capacity is there and is sustainable, and there is a detailed way of estimating that. This is the result of the evaluation of 18 countries of the region. As you notice, it's almost the blue and red, which is yes and no, or the capacity is there. Roughly speaking, 54% of the capacity is there, which means that unfortunately still we are not ready to deal with chemical accidents or chemical events. And one of the main issues that we are losing is non-existence of poison centers and the poor clinical management, let me say, at hospitals. This is in a nutshell, the evaluation of the different aspects of chemical safety. As you notice, the picture is completely different from what we see in the self-assessment a lot of red, which means that the capacity is not there. And one of the lacking capacities is really the poison centers. And actually, in most of the countries, either, see, this is, if I know if the pointer is clear, in most of the countries of the region, either the poison center is not existing or is not functioning to the level that it is serving 24/7 the whole country. In the first indicator, we see clear gaps, and we know the chemical event and poisoning surveillance system is weak or not existing. Chemical laboratories for testing and sampling is weak or not existing. Functional poison center is weak or not existing. I think this is closely related to what you will be discussing in the coming 4 or 5 days. And accordingly, we built actually a plan of action for the countries of the region, in order to bridge these gaps. I'll just browse through those main activities. First is to design and introduce a model event-based surveillance system for detecting and reporting on chemical events, strengthening existing evidence-based surveillance systems for detecting and reporting chemical events, provide technical support to help all countries in having at least one functioning poison center, strengthening the laboratory capacity of countries of the region for sampling and analyzing chemical public health concern, technical support to help countries in maintaining reliable access to information, and strengthening the capacity of the health sector for assessing, communicating health risk on chemicals. I don't want to go in all the details. This is a very rough talk about what we are planning in the coming 3 or 4 years to help countries and region in responding to chemical issues. And back to you.
Thank you, Mr. Mazen. I think your points are very important and actually really validate why we are here today. And it's actually an opportunity for us in the MENA region as toxicologists and public health professionals and emergency physicians. It's an opportunity for us to build on the attention that is given to us by WHO and call to action to enhance our chemical toxicology, or medical toxicology, clinical toxicology, poison center, even laboratory capacity in the region. So I thank you for joining us. I wish you were here with us. Mr. Melkawi is going to be here with us with the network of their network that they formed in the EMRO region. However, the novel coronavirus led to them being occupied with this epidemic, and we had to do this online today. Hopefully, you will join us next year, Mr. Melkawi, with your group.
Inshallah.
Now we are going to keep going. Mr. Melkawi, if you'd like to watch the slides, we are going to keep the WebEx going. And actually, I don't know if we'll be able to do that. Actually, we're not going to be able to do that because of the technology. We will share with you those slides for the Poison Center updates. I can email them to you afterwards so you can look at them. But we are going to go through now several countries' updates about their poison centers. And we are going to start with Qatar, with Dr. Lina Amin. Dr. Lina Amin is a clinical toxicologist who is the director of the Sidra. Did I make a mistake? Well, pharmacist and clinical toxicologist. Yes, clinical pharmacist and clinical toxicologist, director of the Sidra Poison Center in Qatar. And she's going to give us an update about the Qatar Poison Center.
Good morning, everyone. Good morning, everyone. My name is Lina Amin. I'm the manager of the Qatar Poison Center in Doha, Qatar. And I'm a clinical pharmacist by training. And actually, I'll tell you a little bit about myself. I got my doctorate of pharmacy at Mercer University in Atlanta, Georgia. And after that, I moved to Chicago, Illinois to do my pharmacy practice residency at the University of Illinois at Chicago, and then did some emergency medicine training and actually worked as the emergency department clinical pharmacist at the University of Wisconsin in Madison, Wisconsin, before I ended up moving to Qatar and helping start the Poison Center there. So I'll tell you a little bit of history about Poison Center and toxicology in Qatar. So if I know some of our colleagues from Qatar are here and can attest to this, but Qatar is a booming nation. It is rapidly developing. Some of you may be aware that Qatar 2022, the World Cup will be hosted in the state of Qatar. And with that, the infrastructure and development in the country is going at an astonishing rate. And that's not just for the infrastructure and the amenities that are available in the country, but also for the healthcare sector. The availability or the state of toxicology services, and found that there was really a lack of, obviously, a poison center and no standardized tox services available. A series of events then led to the development of the Qatar Poison Center, which has been running now for a year and a half. We opened October 1st, 2018, and it's the first and only poison center in the country. Some of you may, I don't know if you can see very clearly on the map, some of you may recognize it. It's actually the WHO directory of poison centers around the world. I wish I had thought of taking a screenshot of the before they recognized us as a poison center. So I could show you that, like, Qatar didn't have a red dot. All the red dots on the maps are actually poison centers that exist around the world. But before we opened the poison center, Qatar did not have any poison center established and didn't have any recognized resources available. But with the opening of the Qatar Poison Center, we were able to get that red dot on there for us. And to me, that's a small, big win in a way. Okay, so with our services at the Qatar Poison Center, if you were to visit us, which I encourage everyone to visit Qatar and come see us, we're practically identical in structure, organizationally, and in function to a standard North American model of poison centers. I know the Georgia Poison Center has some additional public health activities that we don't, but in general, our functions are very, very similar. We're staffed by US-trained and board-certified medical toxicologists and clinical pharmacists who are also specialists in poison information, or what we refer to as SPIs. And we run the call center that serves the entire country, but we also, where we dispense poisoning management advice, but we also have additional activities like research, education, training, and lots of public outreach. So Dr. Ziad mentioned that we're Sidra Poison Center. We're actually the Qatar Poison Center, but we're located at Sidra Medicine. Sidra Medicine is a state-of-the-art tertiary care center for women and children in Qatar. It opened, the outpatient clinics, I think, opened 2015, and then the hospital opened in 2016. It's an amazingly, incredibly beautiful building. It's probably the most beautiful hospital that I've ever worked at, and probably will work at. I have some pictures on there that you can see. But Sidra was, or is, part of Qatar Foundation. Qatar Foundation is a non-profit organization in Qatar that was actually founded by Her Highness Sheikha Moza bint Nasser, who's the mother of the current emir. And it's comprised of over 50 academic research and healthcare facilities that serve the country. All right, so what do we do at the Qatar Poison Center? Well, obviously, our bread and butter, what we do every day, is to manage poisonings. And we do that through our nationwide poison helpline, through our call center. We also promote the development of toxicology in Qatar through education and training. We're involved in research, and we're heavily involved in public education, promotion, and awareness about poison prevention and management. And I'll discuss each one of those further. So for poisoning management, as I mentioned, our bread and butter, our day-to-day activity is providing care through our call center, which really serves everyone in Qatar. We get calls from public, we get calls from healthcare facilities all over the country. Surprisingly, we've actually had some international calls as well from over 10 countries over the past year. It's always a pleasant surprise to hear someone talk from, or request your advice and help from somewhere outside of Qatar. So it's nice to know that our reach and our help is able to extend beyond our borders. And our clinical management of poisoning complies or is standard with guidelines, policies, and procedures that follow regular standard of care that's in the US. Who works in the Poison Center? So our Poison Center, our call center is staffed by specialists in poison information, or SPIs. They're all PharmD, so they all have doctorate of pharmacy degrees with specific background in critical care and or emergency medicine, and they've received some specialized additional training as specialists in poison information. They are the ones who receive the calls from the public. They're the ones who receive the calls from physicians, nurses, pharmacists, and various healthcare facilities all over Qatar. And they triage and manage those cases, they document them, and sometimes they involve our medical toxicologists in certain cases depending on our guidelines. And they're all, actually everyone in our poison center is bilingual, speaks Arabic and English, except for our medical director who only speaks English. Our call center is also fully electronic. We have online resources. We also document all our cases in a database that we maintain. Some of you are familiar with it from the US. And we have a very advanced telephony system that supports our large-scale functions. As far as education and training, as I mentioned, this is something that is part of the vision of the Qatar Poison Center, is to develop toxicology in the state of Qatar. We actually have started a medical fellowship in toxicology that's soon to be ACGMEI accredited. We actually have our first fellow from Kuwait who started in July 2019, Dr. Abdul Latif. Yes. We also offer lots of poison center rotations in toxicology. We've had medical students from Weill Cornell and also from Qatar University. I also precept pharmacy students in both the Bachelor's of Pharmacy and the Doctorate of Pharmacy programs from Qatar University, and I do some teaching at the university as well. We also offer the Specialist in Poison Information training that's specially tailored and customized to what a spy would need to do or how they would need to function in a poison center in the Middle East. So it takes into account the challenges that they would face, takes into account language issues, and is really a fully comprehensive, very detailed, very intensive program. And we've also hosted several BHLS and HLS courses and others throughout the year. Just as this is for our medical fellowship program, just wanted to let everyone know that we are actively accepting applications. And if you have any further questions, you can speak to me or to our medical director. So in addition to our education training, I'm really proud to say that in almost less than 1 year since we've opened, we have completed 10 research studies. We've had 7 abstracts published and presented posters and or oral presentations at 13 local and regional conferences. Actually, one of our spies right now is presenting some of our studies at a primary healthcare conference in Qatar. Actually, I think her presentation was or is tomorrow. And we're also heavily involved in public education awareness. Public health awareness is not an area that's highly developed in Qatar, especially poison prevention. And so we have, over the past year, we have been involved and active in a lot of public events, public holiday events, health fairs, and pretty much every opportunity where we could have access to a large gathering of public, we've made sure to attend. And it's always gratifying to have people come up to you and say that they've called you, that they've spoken to you, that you've helped them in some way. We've also introduced National Poison Prevention Week to Qatar. This is something that did not exist before, and we've copied the idea from the US. And we did host an art contest for students from schools all over the state. Last year we had over 600 applicants or art entries. So it's always really nice to kind of have the public get involved and become aware of poison prevention and just what you can do to serve them. Obviously, other than that, we've participated in media appearances, and we have social media accounts that we use to raise awareness further about the Poison Center. So if you're not following us, you can follow us at Poison QA. And with that, end my talk.
Thank you, Dr. Dina.
Any questions?
I follow you on Twitter.
Thank you.
Thank you. Can we leave the questions till the end, Mazda, because I have to keep going. And then Dr. Badia Hattali, Director of the Oman Poison Center. Dr. Hattali completed her fellowship at Emory University in medical toxicology. She's also an emergency physician consultant at the Royal Hospital. She's also working as well at Hamad Medical Center in Qatar. So she has multiple hats. And she is a board member and treasurer of Minatox. So she has all the money.
That's not completely true, by the way. Good morning, everyone. Thank you so much for being here and helping us with Minatox 2020. We are delighted to have all of you. And we would like to thank EBAT for hosting us this year. I've been giving an updates about what is the process and how we are doing in Oman for the last probably like 2 or 3 years. So this is just a follow-up of what we are doing so far. So we are in Oman, we are like a population of around 4 million. Half of us are Omanis and half of us are expat. And you can see that, you know, there is a challenges when it comes to the kind of the exposure that we are facing, because it's like a different, we get like from different countries all over the world. If you look at the outpatient morbidity in the Ministry of Health, and this is for the last update 2017, you can see when it comes to the injuries and poisoning, we are just like way down compared to communicable and non-communicable diseases. And so it was really hard and difficult to convince the ministry how important is this specialty and how do we need to advance care in this field. Now, the majority of the cases that we are seeing are in pediatric population, and most of them are unintentional exposure. Though we see some of the occupational and environmental exposure, which is quite significant in the country. When it comes to all outpatient morbidity, there are around, this is basically based on an ICD-10 coding, so we are not 100% accurate, but we see around 90,000 cases related to toxic exposure per year. And when it comes to the inpatient morbidity, there are around 900 cases. Now, the vision to start the poison center in Oman was started in 2015, and that's basically after I finished my residency and my fellowship and joined the Ministry of Health. We struggled to have a section, like let's say poison control section in the Ministry of Health. But eventually, we were able to establish that, and we published it by 2018. So now we have what is called a poison control section, which is part of the occupational and environmental health in the Ministry of Health. We are currently 4 medical toxicologists that have been trained in US, including me, Dr. Nadia Al-Hajri, Dr. Suad Al-Abri, and Dr. Walid Al-Sukaiti. That being said, all of us do a hospital-based service, medical toxicology service. So most of our job is basically related to seeing patients in the hospital and giving advice rather than a proper poison control center. The whole process is meant in collaboration with the, as I said, Ministry of Health, the contact center in the Ministry of Health, and the Oman Medical Specialty of Port. And the reason why the medical specialty was involved in this, because we were trying to push further this subspecialty and get the attention of the Ministry of Health. So the current situation where we reach, as I said, we will be able to establish a section in the ministry which was not there before. We are running multiple workshops and educational activities for the hospitals related to the Ministry of Health, and we did not reach to the public yet. We were able to do some sort of guidelines and policies, and we were able to distribute them in different institutes in the Ministry of Health in collaboration with the Minatox. Dr. Ziad Kazi was a lead in that. We also sent leaflets and educational materials about different aspects of tox-induced exposure in the country. Let's say, for example, snake envenomation, scorpions, different plants, different household products as well. Within the guidelines, we list some of the antidotes that is available in the country and where they are located, so that was easy for them to know exactly whom to approach, but we did not have a dedicated line. So most of the antidotes are not actually allocated in one place, but we have a pool of data that, each hospital has this kind of antidotes, and so we were able to approach them if we needed. That being said, we are lacking like few expensive antidotes that is not available in the country. We also created somehow minimum, or let's say a minute triage dosing list for the primary health care facilities, which is the main, most of our cases, they go to the health centers, and then from there will be referred to the hospital. So we said if we provided this kind of list for the most common medications in the country, maybe we are decreasing the load on the hospitals by doing that. And we also created some charts to help them with the management of the most common exposure in the country. Now, when it comes to the laboratory capacity, we have a small lab within the section that runs basically heavy metals. We don't do more than that. And the reason why we are having heavy metals on board, because we see lots of cases related to mercury and lead exposure, specifically because of the preparations, like the local or the traditional medicine that's been used, quite common in the country. The last step that we approach is we asking the contact center in the Ministry of Health to take our calls. And we are starting to train the nurses in the center basically to receive and triage the cases for us. So let's say, for example, a patient who's coming in the primary health care, we have a facility which runs from 7 a.m. till 10 p.m. at night. So we are covering that section basically with a direct line that can give an advice whether they need to go home or they can be referred to the health center. And we have the medical toxicologist will be 24/7 on call for that facility to give us. In terms of the surveillance and database software, we had a manual notification forms that's basically entered through and fed through the EB data, and then that goes directly to the surveillance department in the Ministry of Health. And recently we will be able to change it to the electronic notification. And so we get, direct number of cases from all the institutes that belongs to the Ministry of Health. Now, we were able to create electronic data entry system in the contact center, which is basically similar to the notification form that we distributed. And this is basically will give demographic feature, the kind of exposure, and the follow-up for the patient as well in an electronic form, which is locally prepared and distributed. So hopefully that will work. We are still in the first year of using that one. Now, the challenges that we are facing, I guess it's the main thing is that we still did not convince the ministry how important is to advance this care, and one of the challenges is the financial support. Unfortunately, because of the crisis that the country is going through, we could not advance this in a rapid way. The human resources have been asking for more and more toxicologists, more of poison information specialists that can provide the care for us, the equipment, facilities, and technical support, of course, to increase the laboratory capacity. And there is a step forward in terms of the Central Public Health Lab, where all of this will be integrated together. We have issues with toxicovigilance. We don't have that yet in the system. We have only a simple surveillance system, and that should be. And then we started with the collaboration with different countries in order to help advancing the care, and hopefully we can reach somewhere in that. So that's basically an update about what is going on in Oman.
Thank you, Badriya. Some of updates about the Kingdom of Saudi Arabia's poison centers. By the way, for Turkey, there's a session on Turkey. We are going to collapse it with the afternoon session on Turkey. So Dr. Ainur Shaheen is going to do the Turkey update in her afternoon lecture. We did that because we had to add the WHO speaker last minute.
Good morning, everyone.
Dr. Al-Maliki, sorry, Dr. Al-Maliki is currently a medical toxicologist in Riyadh at King Saud Medical City. He's actually probably the first medical toxicologist in the MENA region whose salary and job description includes medical toxicology, bedside care, consultation at the hospital. And he actually completed internal medicine training, and we will not hold that against you, Dr. Maliki. And then a fellowship in toxicology at Emory University.
Good morning, everyone. I would like to give you a brief background about the poison center in Saudi Arabia and the toxicology services. I'm internist and working at King Saud Medical City in Riyadh as consultant internal medicine and medical toxicologist. So I has nothing to, no conflict of interest to declare. So basically, what I'm gonna cover in my presentation is I will give you like a history about the poison center development in Saudi Arabia and what they do. Plus, I will share with you some numbers from the previous years, and at the end, I will give you an overview about toxicology consultation services in the kingdom. So, as you can see here, this is the mortality rate secondary to unintentional poisoning in the MENA region. As you can see here, rates are very high in both African and countries in the Middle East, like 3.8 and 3.5, as compared to other countries in the world. Despite having this high rate of mortality secondary to unintentional poisoning, there is a huge gap in poison centers in the MENA region. If you can see here, this is from WHO. This is the map of the poison centers all over the world. Like if you can see, there's a gap in poison centers in the MENA regions as compared to other countries in the world. So again here, just to show you like few poison centers in MENA regions. What about poison centers in Saudi Arabia? Poison center in Saudi Arabia, like under umbrella of the Ministry of Health, and there's like a General Directorate for Poison Control Centers. Basically, the first poison center in the country has been established like 40 years back. It was in Riyadh. Year after year, some other centers has been opened in other areas in the country. So as you can see, this is the map of Saudi Arabia. Saudi Arabia is like one of the largest countries in the Middle East. The population is around 30 million. So there is 13 poison centers distributed all over the country. We have the first poison center that has been opened in Riyadh. Also, we have poison centers in other regions, like we have in Dammam, we have in Jeddah, in Mecca region, in the south, in the north. So basically, the total number is 13. So poison centers in the kingdom is like the function is not similar to the US model. They have different rules and functions. Basically, they have different functions. They have consultation services for drug and poison information. Also, they are handling some lab stuff. So they are doing forensic toxicology lab, also TDM, plus also they are doing like screening for drug of abuse for both like workers or even from healthcare facilities. They are doing some occupational and environmental toxicology, like screening for substance of abuse, biological monitoring of pesticide, plus trace metal analysis. Is poisoning issue in the Kingdom of Saudi Arabia? I will share with you like some data from 2017. This was like cases that has been reported to the Poison Control Center in the Kingdom. Total number of cases was 12,566. Still, this does not represent the whole number of cases. These are the reported cases. We have large number of cases not reported. Majority of cases were in kids under 6 years of age, and 12% of them has been admitted to the hospitals. 2/3 of the cases came from the public, while 1/3 of the cases came from healthcare facilities. So just if you will see here, 85% of cases occurred in children less than 6 years of age. In terms of substances that has been encountered, different substances like vitamins, corrosives, chemicals, hair dye, antacids, corrosives and chemical constitute the majority of cases. In terms of most commonly encountered medication, so vitamins constitute 13% of the cases, while exposure to paracetamol constitute around 8% of cases. So recently, over the last few years, what we did, we established a new hotline to receive consultation for poisoning and issues related to poisoning from healthcare facilities. So just for hospitals, if they have like someone in the emergency department and he need consultation regarding a patient with drug overdose, they will call the hotline 1937. So then if the caller is from healthcare facilities, calls will be handled by a medical toxicologist. But if the call is coming from the public, it will be handled by a general practitioner and sometimes clinical pharmacist. So basically, the medical toxicologist at the time being, we are only covering calls from healthcare facilities. So what we do in the medical toxicology consultation services, we are doing different tasks. We are handling consultation for poisoning and poisoning related issues. We are doing training staff, delivering courses in the field of medical toxicology and some public health awareness. So basically, if a medical care facility, they have a patient who was exposed to a chemical substance or intentionally ingested any medication, what they will do, they will call 1937, and again, the call will be directed immediately to a medical toxicologist in call. We are covering 24/7. We have 12 medical toxicologists on the service, covering all hospitals from all governmental and even private sector in the kingdom. We give immediate advice about how to manage this patient disposition and follow-up. For some cases, if they need bedside consultations, we provide bedside consultations for some like critically ill patients, or in case we need to do that, plus follow-up. This is basically what we do for the consultation service. We are doing training during this service. We have trained fellows. Majority of our fellows are pediatric emergency fellows. So they rotate with us like for 4 weeks. And they are the first one or the first on call for the services. Then they will discuss the case with the on-call medical toxicologist. Also, we trained residents from different backgrounds, majority from emergency medicine, but we have residents from rotating in ICU, pediatrics, and internal medicine. Also, we trained some clinical pharmacists. This is in terms of training. In terms of courses, we are trying to increase awareness about the importance of toxicology services in the kingdom. So we are conducting training courses in medical toxicology all over the kingdom. We covered 6 areas per year. The courses are directed toward emergency physicians, GP, and even nurses and pharmacists. Basically, the course is like 2 days to cover main aspects of how you can approach poison patients and management of these patients. Also, what is the impact of this service? Is it important, like, to have toxicology service? Yes, there was a huge impact in the kingdom. So, impact came in patient care. So it has been found that a lot of unnecessary investigations has been stopped, unnecessary admissions to the hospitals, unnecessary antidotes, even unnecessary visits to emergency department. So it has impact on patient care, the mortality rate, the cost, again, a lot of unnecessary like investigations, drugs, etc. Has been saved, resource utilization. Previously, before we have this service, like each hospital is working alone, like each hospital will stock its own antidotes, and some of these antidotes are very expensive. Now, after we have this service, we can share the resource between different hospitals. Like if we have someone who will need fomepizole and it's not available, immediately we can allocate resource from other facilities in the same area. So it will help them to save money. So unnecessary like antidote stocking has been decreased. Public health. After the service, like we have been involved in a lot of outbreaks. Like for example, last year, because we received like 4 or 5 cases about methanol in different hospitals in the same area. Without having this service, you will not discover these scattered cases. But because we receive over like 24 hours, we received like 5 cases of methanol in different hospitals, and this has been raised to authorities, the Ministry of Health, and it has been found that the common source was like contaminated juice in one of the restaurants. Needs assessment, toxicology, medical toxicology services helped the Ministry of Health to know what is needs for medical toxicology. Now they know how many cases we have per year. They know, like for example, how many cases of ethanol or methanol would we have per year, so that they can plan, for example, where to have antidotes, which area is in high need for this antidote or that. Before having this medical toxicology service, these figures were not there. What we are planning to do in the future, we started to have training courses for specialists in poison information. Last month, we trained 15 new spies. The majority of them, like if you can see here in this, the females are clinical pharmacists, the males are nurses. So we are planning to recruit these spies and to be like a first responder for to receive calls regarding toxicology from both healthcare facilities and the public. They will do like triaging for the cases for us. We are preparing specific guidelines for them to know which case to be managed at home, which case, when to refer the case to medical toxicologists, which cases to be referred to healthcare facilities. Still, we do not have a lot of awareness in public health about poisoning, chemical safety, etc. So we are planning to have more awareness programs in the future. Also, we are hope that we will have a fellowship in medical toxicology in the future.
Thank you. Thank you, Dr. Malki. Our next speaker is...
Good evening, everybody. And this opportunity, I would like to thank you, Dr. Ziad, for his logistic and scientific support. In fact, I will talk about a brief introduction about poisoning control, Baghdad Poisoning Control Center. Yeah. Baghdad Poisoning Control Center located on the ground floor of Al-Ghazi Hariri Hospital for surgical specialties within the medical city complex. It is established in 1998. It is nearby the General Emergency Departments of Baghdad Medical City, about 2 meters. About the infrastructure of our poison control center, in addition to the administrative departments, we have an information department for which usually the patient presented for either consultation or information of agent. Of course, a special case report form were done, and after that, after interpretation of the whole presentation and clinical picture, we usually send for the command toxicological unit or screening in the other department, which is called laboratory departments. And then these data were kept in a special statistic unit for research for retrospective studies. Why Poison Control Center is important? As I said before, it provides a database about the drug intoxication and chemical exposure that involve our local society, and has the ability to diagnose and to suggest the guideline management for each type. Second, training services for emergency departments. We are a part of the training courses of those in emergency medicine, pharmacists as a clinical toxicologist or non-medical toxicologist, and biochemists. In fact, many research have been achieved with the aid of these animal statistics, retrospective studies like lead poisoning, organophosphorus, and so on. And the information about any agent, it is always available, and about the antidotes, indication, uses, side effects. Also, its role in participation in mass gathering people exposure and CBRN teams. In fact, how does it work? Either directly, the patient presented by his relative, with his relative, for example, chronic lead poisoning, thallium, or indirectly by phone call or written request. In this case, we ask for the complete data about the clinical picture and complaint and their investigations. Also, we ask a blood and urine sample, gas clavage, or a container of the suspected drug to be poisoned. This is a summary of the mean number of patients presented with positive clinical finding and confirmed by laboratory diagnosis. For example, of insecticide people exposed to, whether it is organophosphorus or organic chlorinated compound or pyrethrin, about 60. This is the mean level, and usually presented from the emergency departments. Paracetamol poisoning, I mean paracetamol poisoning, not overdose. I mean it is more than 150 milligram per kilogram body weight. And of course, the guideline management for all of these patients usually supported by the Poison Control Center. In addition to our work, there is a special request from other, for example, GIT centers, it is about 100 and 250, in order to exclude Wilson's disease, because the availability of these devices for levels of estimation. There is certain historical events during the last 20 years. The Poison Control Center plays a major role in diagnosis of something that have a major effect on the community, on the health, on the environment. For example, this is one of them. In 2,000 years, there are more than 2,000 cases of lead poisoning reported to our poison center. This was recognized at that time because of first, they were using a tetraethyl lead in order to increase the octane number of petrol in oil refinery system. The second reason, that lead oxide leads for batteries locally made in a closed ventilated room. During the period of embargo in low socio-economic states, most of people recycle the old batteries. And usually you should change the lead oxide plate for these batteries, which was illegal and does not meet the requirements of Ministry of Environment. I mean, it is not licensed. Of course, many of them are presented even of fit encephalopathy. We have treated so many of them with combined therapy, BAL, and calcium disodium acetate. Another important historical event, this is during the wartime, kidnapping and theft by using benzodiazepine, lorazepam, clonazepam, midazolam, or directly spray directly over the face, or these substances usually injected to the Pepsi or any juice cane. The taxi driver are the most likely victims. Another historical event which happened, criminal, most likely, from 2008 up to 2015, about 82 cases reported. It is included, also Al Jawiya Sporting Club, it is included in these statistics. The first one, this is the most likely patient presenting usually crippled and alopecia. This is the most likely with subacute or chronic poisoning. Sometimes they presented with alopecia alone, or rarely it is presented with a bluish discoloration or desquamation of the skin. Another historical event, mustard agent by ISIS. In fact, Taza village involved, which was belonged to Kirkuk city, the former number was 60, and the public number is thousands. Also, many of our soldiers exposed in Abar region, and there are so many times they were exposed to in Mosul city, many times, 10 times. This is the most likely, Abulle is the most likely typical appearance of a blister agent. Chlorine gas exposure for more than 10 times. This is an example. Al-Taji area, more than 100 people exposed. Al-Sadr area, more than 300 people exposed. We treated them, we gave them the major guideline for the treatment of chlorine gas. Yeah, this is the mass gathering people exposure during a religious celebration. In fact, millions of Al-Shia usually walk to the Imam. In this religious activity, we have to support them by referring a special team to walk the medical team at that time in case of poisoning. These are the usual antidotes available nowadays in my center. In fact, the antidote is problematic for all of them. We don't have, for example, FAB for digoxin and other, some of them are deficient. Of course, there are atropine or naloxone are available in the other departments, like anesthesia and so on. These are the devices that usually used by my lab. The first one is atomic absorption. We have 3 devices. In routine work, we measure copper or lead, but for some research, of course, we can measure some other materials like cadmium and so on. Spectrophotometry device and telechromatography, these are both procedures for drug screening test and HPLC. A new device were added nowadays for therapeutic drug monitoring and drug of abuse, still in the process. We hope in the future we can estimate the serum level estimation of some drugs. Our vision for the future, the antidotes should be available all over the time. Updating our devices, for example, GC-MAS and ICP, inductively coupled plasma emission, and isolated equipment and fully equipped with high-skilled medical personnel. A new academic study in clinical toxicology that offers a master or board-certified region participation in scientific conference in this field. Thank you.
Thank you, Dr. Hamoudi. Last but not least, Dr. Tarwa is going to give a brief presentation, followed by lunch.
So the slides will be there, right?
Yeah, we can see the slides.
Good morning, everyone. Good morning, everyone. So basically, in Lebanon, we do not have a poison center. We have a toxicology service. And this service was established in 2015, and really all the efforts go to Dr. Ziad Azzeh and Dr. Evelyn Hatte, our chairperson of the Department of Emergency Medicine. And and I recently joined in 2018, and we are co-directing this service, myself and Dr. Kazi. It's an MOU between Emory University and AUB. It's basically a telephonic consultation service that's offered to the healthcare providers, the patients also who present mostly to the emergency department. And lately we've done agreements with other hospitals, so now they have our call system. They can call us, but not really from the public. And it's a 24/7. There's a call system. The first on call are the international toxicology fellows at Emory University. And it is directly supervised with different attendings. Myself, Dr. Kazi, and we have Dr. Brent Morgan from Emory University. And we have collaborations with the Emergency Medicine Department, the hospital pharmacy, the lab, and environmental core lab for additional testing. The Emory faculty team, Dr. Brent Morgan, Dr. Pomerlew, he's now in Australia, and Dr. Melissa Gittinger. Our toxicology officer, Ms. Zaina Mnaimni, who maintains the data in RedCap and follow up on the patient 24 to 48 hours after discharge from the emergency or from the hospital if they got admitted. And we recently published our data at Clinical Toxicology. We basically reported, it was a descriptive analysis, and we reported on our challenges. And recently we're working on another paper to report on how this tele-service works, maybe other areas in the Middle East or the areas where there's no clinical toxicology service could benefit from this. Mostly the age group that we had most of the ingestions were from 20 to 50 years old. And interestingly, the pediatric exposures, 24% occurred in children less than 5 years. And these typically are unintentional ingestions, we know that. And if we have a poison center, they could easily be triaged without really presenting to the emergency department. And here comes the benefit of having a poison center. And we're looking at this subset specifically now, myself and Ziad, to see how many of those could have been just triaged at home without even presenting to the ED. In the US, 12% of the children who had the toxicological exposure were managed at a hospital, and the majority really could be triaged through a poison center. We had a predominance of female in general, and specifically those who had suicide ingestions were mostly females, and we're looking at this subset separately now and just analyzing them to see what really were the risk factors for this. In the age group that were less than 12, we had female and male nearly equal, but in the adolescent and the adult, females just had the majority of exposures. Mostly we had unintentional, and interestingly that the intentional was around 51.6%. Usually unintentional are more than the intentional exposures, but in our setting, but we have some limitations. This is just one toxicology service at a big tertiary center. Household chemicals were mostly unintentional in children, and this is mostly because of improper storage. We do not have really any child resistant. We do not have a poison center that spread awareness regarding the safety and safe storage methods at home. And the top 5 pharmaceutical exposures that we had were mostly sedative, analgesics, antidepressant, cardiovascular medications. This is similar to the AAPCC US data, except that we had more of sedatives and antipsychotics. Among the non-pharmaceutical, we had cleaning household exposures, pesticides, bites, and stimulants who were among the top 5 categories. Some interesting data is that we know all this opioid crisis in the US and other areas. In our country, we had more of benzodiazepines and sedative exposures. And this is part of it because people perceive benzos and sedatives as safe compared to opioids. And we're looking at this separately now in an ongoing research study, myself and Ziad. So this was the most category that we had. And acetaminophen, like other data in other areas in the Middle East and in the US, was the most reported pharmaceutical. We do not have IV and acetylcysteine. We use the PO. We've been doing well with the PO and acetylcysteine so far. We didn't have really any issues, and it's really excellent. The benzodiazepines, as I mentioned, really is a common problem in our country. People are really more just scared to use opioids. And even we have another thing is that other than the perception of the patients, we have regulations regarding dispensing of opioids. We only have tramadol that requires a prescription. We do not have like Percocet or other really medication that could be dispensed. And just at the hospital, you have the morphine. So this regulation helped in limiting the opioid misuse and overuse. Special situations, we have Diongzit. I don't know if you're familiar in some areas in the Middle East with this medication. It's banned in the US. It's a combination actually of a very terrible combination where you have an antipsychotic and a tricyclic antidepressant, melitaricetam, and it is very commonly used. I mean, literally people would go to like death ceremonies, you will have Diongzit. It's something like, if you're stressed, they will take a pill of Diongzit. This is very commonly used. And also we're looking at this separately. And it was reported in our 13 cases of our exposure. We had also interesting cases that led to death because of a tumescent liposuction that occurred at clinic, mostly with lidocaine. We had 2 cases. And an intragastric Botox that led to bad neurological outcome. Also, this was used. And also we had other non-pharmaceutical environmental exposures due to Datura stramonium, where patient presented with an anticholinergic toxicity, and this was also common. Another special situations where we had elemental mercury. It's still used in some areas, not that common, but it's still used. And pesticides, we also had lots of pesticides, and lately we just took care of a severe pesticide exposure. And cardiovascular drugs also, it's very common, and this was among our top 5 pharmaceutical exposures. We have limitations of antidote. We do not have the digibind for digoxin, though digoxin is very commonly used. I use it in my emergency department because we do not have the IV diltiazem. So it's commonly used, and surprisingly, we do not have the antidote for this. But we didn't have really much cases. We had 2 cases, and one of them, because of the use of a Jamaican stone, more of an Ayurvedic medicine, where the patient presented with a ditch toxicity presentation. That was managed with supportive care and eventually did well, luckily. For the snake antivenom, we do have it, but we do not have a local production for that. We import it from Syria. That it mentioned on the leaflet that it covers our 3 poisonous snakes. Currently, for a short time, we had a shortage because of the situation, and we were importing from different areas, but now we have it back in stock. We do not have, at our university, because it's more in the urban, we really do not see much of the snake envenomations. As far as for the medical outcome, most had no effect or minor effect. Few had the moderate to major, and we had 3 deaths in our data. We took care almost of more than 500, but at the time, 477 patients were analyzed in this data set. And the deaths were mostly due to lidocaine and tricyclic antidepressants. 18% left AMA, and this is something common. I mean, we have some limitations. Also, insurance companies do not cover for poison exposure, and usually the families want to discharge the patients, but usually there is a family member. But we managed to follow up through our officer on 46.6% of those patients were followed up, and they did not have any major events. We have future plans. We're now trying to collaborate with other hospitals to increase the use of this telephonic service, and to collaborate with the Faculty of Health Sciences, with the MOPH, and hopefully we will have in the future to train toxicology fellows once we increase our team. Thank you so much.
Thank you, Dr. Wat. Thank you. The US model. Dr. Lina Amin. You want to go up here so you can use the microphone? So the question is, why did the Qatar Poison Center decide to use the US model? And the question is from Dr. Mazda Shirazi, who is in the US model as well. So.
I run one, so I know.
Partly because we recognize that the US standard of Poison Center is the most established and most developed, with lots of supportive data that show the influence and the reach of those poison centers in their communities and in their states. Partly also because I trained at the Georgia Poison Center, our medical director is US trained, we all have, most of us have US training. But yeah, I would say because of just recognizing the US Poison Center model as being, after observing the other poison centers around the world, just being maybe the most organized or the most systematic in their approach, with just better support and better funding and being able to reach their communities better.
Any other questions? After lunch, we are going to tackle education and practice of clinical toxicology in the MENA region with a panel and some presentations. We are going to look at a specific example of a medical toxicologist supporting an outbreak of lung injury from vaping products in Illinois, in Chicago. We are going to also talk about chemical security and chemical inventories, and then finish up with a look at forensic toxicologists. What do they do and how do they interact with clinical toxicology? And a brief session on lead poisoning. So that's what we have for the afternoon. Sorry we took into your lunch break. Enjoy. And please come back 10 minutes after the scheduled time. So instead of 1:30, come back at 1:40 so I don't owe you any time. Thank you. The afternoon session, after your long lunch break, it's my pleasure to introduce Dr. Trevon Thompson, who's a colleague, a dear friend from Chicago, Illinois. Dr. Trevon Thompson is an emergency physician and a medical toxicologist. He trained in toxicology at the Toxicon program in Chicago and is currently the director of the Division of Medical Toxicology at the University of Illinois at Chicago. Dr. Trevon Thompson has had a unique opportunity and experience in dealing with outbreaks and collaborating with his health department. So we wanted him to share with us his experience in that area. Dr. Thompson, thank you.
Thank you. Alrighty, good afternoon. I have the challenge of being the first speaker after lunch. I hope you can stay awake. I am Trevon Thompson. I'm a medical toxicologist and emergency physician at the University of Illinois in Chicago, and I want to talk to you about a few things here this afternoon. Most importantly, maybe I have no conflicts of interest to disclose. Probably important when talking about poisons, so I'm not trying to facilitate or encourage poisoning. I want to start just a little bit by giving a little bit of background before I go too far into my talk, and that is to talk about medical toxicology in the United States. I think you heard a little bit about this morning when Dr. Lopez was talking. You're going to hear some more about this from Dr. Wax and some others, I think, this afternoon. But I think it's important that we understand kind of some foundational background from where I come from in talking about some of how these outbreak investigations have occurred. So quite obviously, I think, we may know now that medical toxicology is a subspecialty. In the United States, it is primarily a subspecialty of emergency medicine, though there are other pathways into medical toxicology, internal medicine, pediatrics, preventive medicine, et cetera. But it is an organized subspecialty that requires fellowship training. It's a 2-year fellowship training program. There's a certification exam, and then there's maintenance of certification. This is all important, I think, in understanding that medical toxicology is well developed, as was talked about earlier this morning, in the United States. And we have a built-in collaboration with our Poison Control Center network and the National Poison Data System. So through our poison centers, which you heard a lot about this morning, we are able to collect both regional data. So in Illinois, for example, the Illinois Poison Center, we're collecting on a daily basis our regional data regarding poisoning and reports of poisoning to our poison center system. But also all of our poison centers in the United States feed into the National Poison Data System so that we can actually track data on a national level as well. Now that's important as we think about the concept of the medical toxicologist as a collaborator. And I think we are uniquely situated to be a collaborator in many regards. One may also seem obvious, but I think it's worth mentioning. We, at least the way I function in my service at the University of Illinois at Chicago, we are a consultation service. So an internal medicine team or an emergency department or sometimes even surgeons or neurosurgeons may consult us, asking for our recommendations on how to care for someone they're concerned about a poisoning, is poisoned, et cetera. So we're naturally working with many others as it relates to the management of a case. But it goes beyond that. If we think for a moment about those of you in the room today and some of the others that you may have heard from, we collaborate with pharmacists, with nurses, with other healthcare professionals on a regular basis. My division, for example, of medical toxicology consists of 2 pharmacists who have extra training in clinical toxicology. The SPIs, the specialists in poison information who may answer the phone at the poison center, might be a nurse, a pharmacist, or a physician. So we're always collaborating just as a natural function of what we do on a day-to-day basis. With that, I want to highlight a couple of outbreaks that I was involved with and have been involved with. And these are just a few of several, but these are ones that have been published that will really highlight some examples of how the medical toxicologist can function as a collaborator with public health in dealing with poison outbreaks. So this case here, this was a fentanyl outbreak that occurred, not the current one that's going on in the United States, but the one that occurred in 2005. This centered in the Midwest, primarily in Chicago. And there's an interesting story here. So I was a first-year fellow when this happened. This was an evening. I was actually leaving from my office, my fellow office, to walk to my car when I got a page from our emergency department saying, hey, we've got several cases of heroin overdose that are acting a little bit funny. The first thing is that we've got 6 that have come in a shift, and some of them have required more naloxone than regular. So at least in the United States, many times the medical toxicologist is not being consulted for a heroin overdose. That's sort of a routine type thing that you may take care of in the emergency department. So already alarms may be going off a little bit that an emergency physician is consulting us for a heroin overdose, because that would seem ordinarily to be bread and butter emergency medicine. But these cases were unique. Several of the cases were people who were using what they thought were their usual doses of heroin and then immediately dropped, were becoming apneic or unresponsive. Many did require more naloxone than usual to reverse. And then when I started talking to folks after they were awake, some interesting features were going on. In this case, we had 6 in our emergency department at that time. They all said they got their heroin from a new drug dealer, which is always a little bit suspicious. But this drug dealer was giving away the heroin, which is also even more suspicious. No drug dealer is giving away their drugs. But this was a new dealer who was trying to drum up business and had a deal where you could get your first dose literally for free. It turns out, so we alerted the Illinois Department of Public Health to these cases. A larger investigation ensued, and it turns out that there was an importation of fentanyl into Chicago. This was imported from Mexico. This quote-unquote heroin turned out not to be heroin at all. It was all fentanyl, which is why these patients were dropping so quickly. And it turns out we, in about a 1.5 year period of time, had about a little over 300 deaths in just the Chicagoland area. We had 2 at our own hospital. So this is my first introduction to an outbreak as a fellow, but really I didn't know if this was bread and butter yet or something kind of out of the ordinary. So we'll fast forward just a little bit towards the end of my fellowship time. And so this was a report of a case of pufferfish poisoning that we had in Chicago, initially at least. So this was interesting in that through the Poison Center, we got word of a case where a lady, she was of Korean descent, but living in America, went to a Korean groceries market, bought fish labeled as monkfish in English, but labeled as pufferfish in Korean, brought the fish home, prepared a dish for herself, for her husband, and for her daughter. She drank or ate about 3 cups of the soup. Her husband ate about 1 cup, and her daughter just took 1 teaspoon of it. She knew it was pufferfish that she was buying, and just as a quick reminder, pufferfish contain tetrodotoxin, which is a poison that can lead to paralysis and kind of sensory deficits as well. So she eats the soup. She becomes almost immediately symptomatic, has some GI upset, and then develops severe paresis of her lower legs. She developed numbness and tingling in her arms. She had gross truncal ataxia, goes to the emergency department. The emergency physician, thinking this might be pufferfish poisoning, calls the poison center. We're looking at this case thinking, yes, it does certainly sound like pufferfish poisoning, but another alarm went off in that in the United States, pufferfish is very heavily restricted. It can only come in through one route in the United States, can only be sold in certain establishments, particularly restaurants. The regular consumer should not be able to go to the store to buy pufferfish. So our alarms went off with just this one case. We alerted the Illinois Department of Public Health. We actually sent some of our own team to the family's home to retrieve the soup that was ultimately sent off to the FDA and to some other bodies for testing for specifically tetrodotoxin and genetic testing of the fish to prove that it was pufferfish. A larger investigation ensued that led to the determination there was an illegal underground black market importation of pufferfish in the United States through California, and it was deliberate. So again, this fish product was labeled monkfish in English, but labeled as pufferfish in other languages. It was designed to skirt the regulatory guidelines for importing the fish in the United States. Also, turns out that there were 2 other cases of pufferfish poisoning, one in California that actually occurred a few months before ours, but it was never reported. Then there was a subsequent case in New Jersey, all related to the same illegal importation scheme. So again, highlighting a little bit of where medical toxicology can help with collaborations with public health, and I'm going to come back to this in a moment. The last outbreak that I want to talk about is more modern. So this was about March of 2018. In Illinois, our service was consulted on 2 index cases, it turns out. This was a father and son who presented to an emergency department with bleeding, primarily hematuria, and really no exposure for why they should both have hematuria simultaneously and other bleeding. Turns out they looked a lot like rotificum poisoning. Their INR was almost undetectable. It was so high. It didn't really make sense, though, because they had no known exposure. They were both factory workers, and they thought that perhaps there was some dust in the factory they were exposed to. That was the only exposure they could identify. But there was nothing that really explained why this father and son all of a sudden developed a profound coagulopathy. So those 2 cases came into our service through the Poison Center, and we immediately actually alerted the Illinois Department of Public Health in this case as well, mainly because we couldn't understand what was going on. The circumstances did not make sense. So a few days go by. Several more cases of patients randomly sort of showing up in emergency departments in Illinois with profound coagulopathies occur. Through history taking in these subsequent cases, we learned that there seemed to be some sort of association between this coagulopathy and people abusing synthetic cannabinoids. And then we were able to go back to the 2 index cases, ask them direct questions, were you using synthetic cannabinoids? And they answered yes. That actually began the investigation to determine that there was in fact a big outbreak of synthetic cannabinoids contaminated with or adulterated with long-acting anticoagulants, primarily brodifacoum. So I highlight these 3 cases, not to highlight because I was involved with them. These just happen to be 3 cases I was involved in. A lot of my colleagues in medical toxicology have been involved in similar outbreaks. I think if you were to go around the room, you'd find that many, you see some heads nodding here, have been involved in outbreak investigations or alerting public health officials about a potential outbreak. This seems to be a common occurrence within medical toxicology. And so in thinking about medical toxicology and also our Poison Center network, we are often the first to know about a toxicologic outbreak. Our eyes and ears are to the ground, so to speak. We're sort of like first responders in a sense, in that we have a sense of what's going on, whether in your local areas as it relates to either drugs of abuse or pharmacologic agents or what have you. So we tend to have our nose to the ground and can sense when something just isn't quite right, even before perhaps there's a large number of people involved. So what has my experience taught me with dealing with these outbreaks and some others that I've been a part of? And I'll talk a little bit about EVALI, or e-cigarette and vaping associated pulmonary injury, on Friday, so stay tuned for that if you want to come back on Friday morning. We're going to talk a little bit more about that. But I want to highlight a couple of concepts that I think are really important in understanding where the medical toxicologist plays their role in public health outbreaks and collaboration. So I think this is probably obvious. We're all here sitting here at Minatox. Medical toxicology is an amazing field of specialization. I think that goes without saying. In addition to the breadth and depth of cases that we may take care of, we are really in a unique position to, 1, prevent many poisonings, then also manage poisonings, because many poisonings are treatable when you know the right treatment to provide. So we can be a big benefit to not only individuals, that individual patient that we may be caring for, but populations at large. And I think that's an amazing thing that I'm glad to be a part of as a medical toxicologist. This is an important part here. We are truly a clinical specialty, sort of the old-fashioned investigators of medicine. What we do is really take the historical features of a poisoning, the complete, not just the history of present illness, but the complete circumstances surrounding a poisoning, relate that to the clinical presentation that we have based on our clinical exam, and then add to that whatever laboratory data that we may use to then come up with what an answer may be for a case. And a good example might be acetaminophen. You can have an acetaminophen concentration, but without the full picture of what the clinical circumstances, that level by itself is hard to interpret. Pick a level, it doesn't matter which. That level could be different, have a different meaning if it's 4 hours after a single acute ingestion of acetaminophen versus 20 hours after a single acute ingestion versus 4 days after. What if it's a repeated supertherapeutic ingestion instead of a single acute ingestion? Or what if the patient presents with an undetectable acetaminophen level, having told you they took acetaminophen, but your liver enzymes are completely abnormal? Again, we take all that clinical information and kind of put it together like detective work to come up with an answer. There's not a single test, an on-off switch that we can use to make a determination. And it's that little feature, that detective nature of who we are, that's really important in how we can function from a public health perspective, in that oftentimes we may just sense that something is just a little bit off. For example, those alleged heroin cases that I mentioned that we were consulted on, they just didn't seem right. They didn't look like a heroin overdose. That was an alert.